Written? Oh, 2 minutes past.
Okay. Yeah, ready? Dato, ready? Right, you just say hello. Okay, in 1, 2, 3. No live.
Good morning, everybody, and hello. Thank you. First of all, I would like to thank all the participants who have decided to participate in this forum, which is virtual, of course, which we all call it the webinar, organized by G25 and the Edunity Foundation. And this is our very first webinar from G25 for this year. Hopefully, inshallah, we will have more after this, especially if today's one turns out to be something that is very welcome and a success. The topic we're addressing today is something that is so current, so heated, indeed so controversial in many aspects on the COVID-19 pandemic and how we are handling it. Now, a little bit on the G25, perhaps, like I said, this is our very first one. For those of you who are not very familiar with G25, how it all started, it started in December of 2014 when 25 retired senior civil servants felt very concerned over certain trends in the country, namely religious extremism, racial polarization, rather poor governance in some cases, and indeed there was a fear of perhaps the Rukun Negara and the federal constitution being undermined, as it were. And therefore these 25 retired civil servants wrote a letter in 2014 to the then Prime Minister. Since then, the group of 25 has expanded to many more now. I think we are probably more than 50, between 50 to 60 now. And we have conducted several activities in the last several years. Some of the things that come to my mind is, of course, we conducted several public forums, and in the first public forum that we had, we launched a book called Breaking the Silence, which was banned by the Home Ministry and the ban got lifted later on. It's a compilation of essays. We did a study which we call SAIM, which stands for Study on the Administration of Islam in Malaysia. We did a video on vaccination after a few children died of diphtheria because of the belief that vaccines are haram, and we were very concerned about that, so we did a video on addressing the halal haram issue of vaccination. We were very lucky to be called by the IRC under the eminent persons, the Council of Eminent Persons, the Institutional Reform Committee. We submitted 4 reports. One is the report under SAIM. We did a very good report on the need to set up parliamentary select committees, on the need to look at political financing, and on the need to revive economic confidence in the country. And we were very, very gratified that the IRC looked upon our 4 reports in a very positive light. So that's what we did. Can I see the next slide? And therefore now, today, we are having this webinar. As I said, we are addressing COVID-19 pandemic. And if you notice, the title is very catchy, Seeking Solutions. For indeed, we have seen so many solutions either being done or being suggested. Some of them are rather controversial. Some of them are rather something that the public will look with a lot of trepidation. And this is, if you remember, a few days ago, 46 experts wrote a letter to the Prime Minister. You could see the sense of frustration, and we thought that these 46 people thought that there must be a little more coherence in the way solutions are being suggested. So 10 steps are being suggested by these 46 experts. Hopefully the Prime Minister has seen our letter. We still do not know. Now, as you all know, this COVID-19 is a huge, complex, bewildering, is a befuddling, it's really something that is on our minds. It has generated so much confusion and fear. I have no time because we have so little time today. I can summarize the whole thing, what I call the 3 M's. The magnitude itself is the whole world. There is no country that is being spared. In terms of numbers, I mean, just imagine America, more than 20 million, India more than, I can't remember now, 10 million. So by numbers alone is so scary, and the severity. Of course, in terms of mortality and fatality, it is much lower than perhaps SARS. But you can see the severity of the disease. It infects the lungs, you get very bad pneumonia, respiratory system just gets paralyzed, and the fatal cases just go off very fast. So the magnitude is very, very worrisome. The second M is the manifestations. There are serious, wide-ranging economic, social, political manifestations. Today, we can only have time to address the economic manifestations, and we have a very well-known economist, Prof. Jomo, with us. As far as social implications are concerned, it needs another 2-hour webinar for this. I myself, representing UNFPA, I've done at least three webinars or 3 interviews or 3 panels on the social implications of COVID-19, especially on the family, on women, on children, on single mothers, and on the increasing trend of gender-based violence. Do you know that gender-based violence has gone up by more than 200% because of COVID-19? Because husbands are at home, they have nothing else to do, they beat up their wives. Okay, social implications are so huge. Political implications, let's not even talk about it. We saw in the last 24, 48 hours the huge political manifestations. The COVID-19 virus is a very useful, a very convenient political tool to be used, to be abused, I would say. Then the last one is the misinformation. This is one overriding impetus for G25 to have this webinar today, because the misinformation, perhaps I can even add 2 more M's there. There is a lot of mischief in this misinformation, especially from the anti-vaccination group. And of course, there is a lot, some of them are rather malignant. So you can add 2 more M's there. There are misinformation, which is malignant, which is mischievous, and this needs to be addressed quite urgently, hence our webinar today. We have 5 experts on the panel today. Now, every aspect, each of the 5 aspects to be addressed by these experts by itself is a huge, huge scope. The scope is so broad, there's so much to talk, the story is so big, and some are really, really very urgent. However, because of the very severe time limitation, we can only give 15 minutes to each speaker. We do have Q&A at the end, of course. And I know that it's very, very challenging for each of these 5 speakers to pick and choose which one for them to highlight on to benefit the more than 300 or 400 participants that are participating in our webinar today. Now, the Q&A will follow after all the 5 speakers have made their presentation. It will be exclusively using the Slido mechanism. You know what Slido is all about. You first open there's a very easy 4 steps. Open your browser, go to slido.com, enter your event code, which is 1218. Then just write the question and submit it. So this is very simple, and we expect a lot of questions. We hope to have a lot of questions, relevant questions, and inshallah we'll try to address most of it. Now, finally, I would like to just give you an overview of what we are going to look at. Like I told you, we can't do in 2 hours. Like, I wish we can have somebody to talk about the impact of COVID-19 on women and children, on sexual reproductive health, but we can't. We just don't have the time. So Dato Christopher Lee will start off with an overview. Professor Dr. Lokman Hakim will look at because he sits on some international task force with WHO, especially on influenza and SARS, and all those things are related to COVID-19. Therefore, he is a very apt person to talk about the global response to the pandemic. Dato Suresh Kumar will, from Sungai Buloh Hospital, will talk about the national response. I know, Suresh, you are a clinician. It's not easy for you perhaps to answer questions that would be more towards the overall, the KSU and the minister and the DG of the Ministry of Health. So please don't feel worried about that, because we don't expect you to be able to address all those issues, but you can do as much as you can. The 4th speaker will be Dr. Musa Nordin, the pediatrician and neonatologist. There's nobody better in this country that I can think of to talk about vaccine, about COVID-19 vaccine. And I know, because Musa and I, we are in constant touch with one another. I'm simply overwhelmed by the knowledge that Musa has. And finally, the economic implications. This is what it boils down to, what really affects the rakyat of this country. How does it affect every individual, every family, every village, every community, every squatter, you know, is so important. And I know, Prof. Jomo, this again is a huge, broad scope. I can immediately think of economic implications of MCO, economic implications of vaccine, but there are many, many, many more. But I know that the Rakyat are very concerned about the MCO and how it affects, how poverty has perhaps tripled or quadrupled, maybe, I don't know. And this is such a huge, huge topic. So I wish you luck. I really have to apologize to you that I can give you only 15 minutes of the question. Now, I will read the CV of the speaker as they come on the screen to make the presentation. I will now go to the first panelist, who is Dr. Christopher Lee. He retired as the Deputy DG of Research and Technical Support in the Ministry of Health just after the pandemic started. Yeah, Dato, or just before or just after?
Just before.
Just
Good
before,
timing.
yeah.
Good timing, yeah.
I remember that timing. I said, oh my God, we're losing Christopher at such a bad time. So he was the Deputy DG, and that was, I would say, best. Since then, he has been very, very busy in retirement. In fact, I think today, Chris has told us that he will have to leave by 12. We may have to extend a little bit because Chris has another webinar at 12:30. He has been very busy. I know two things that he's busy with at the moment are related to COVID. One is he is a member of the Selangor Task Force on COVID-19. Selangor is very, very lucky to have Chris. And the other thing is chair of the National COVID-19 Mortality Review Committee. So that's a very important post, position that Chris is handling. Secondly, he has many, many other positions. I don't have time in the limited time we have to tell you what else Chris is doing. And as a very basic background, he trained in infectious disease in Edinburgh, Scotland. Came back as a consultant physician in infectious disease, first at the hospital Kuala Lumpur. From then he moved on to Sungai Buloh, where he headed the infectious disease department for several years, and he was then brought over to the Kementerian Kesihatan to be the Deputy DG. So Datuk Chris, the floor is all yours now for the next 15 minutes. Ladies and gentlemen, may I remind you, please submit your question on Slido as the session goes on. We will answer these questions only towards the end after we accumulate all the questions. May I now invite Datuk Chris, please, to make your presentation. I do believe you have PowerPoints.
Yes, I do.
Yes.
I do, Dato. Thank you very much. Thank you for the kind introduction. Thank you, G25, for giving me this opportunity. I have the easiest task compared to all my other colleagues who will come on later. My job is to give you an overview. The easy part of this is there's so much to cover, as Datuk Narimah has mentioned. So I'm just going to highlight bits and pieces of it. But the details, I'm sure my learned colleagues who come after me will elaborate a lot more. But I think suffice to say, last year has been a tremendous year. But looking at the last couple of days of this new year, I think the best or the worst has yet to come. Shall I show my slides now? Can I share my slides now? Are my slides up? Are my slides up? I can't see.
It's okay, you can.
Oh dear.
Oh dear, wait, let me see. I have to share my slides again.
If you remember your slide, you can start talking about the first slide.
Okay, yeah, well, this is just some pictures. I have some difficulty sharing my slides now. Okay, let me just see what I can do. I think all of us know that in the last 1 year, a lot of things have changed in the way our lives have changed. And I think clearly we know that when we talk of COVID-19, we think of, number one, the restrictions that we have been imposed on us, many of them very necessary. And we have not been able to carry on with our social activities, our economic activities, as well as also our normal health delivery system. So basically our whole lives have changed. I think clearly this has come upon all of us in a very short period of 1 year. And this is indeed very frightening. Oh, my apologies. My slides. Oh dear. Oh dear.
Can we get
my
the slides?
Yep. I have to look at my slides again. It's not here. I apologize. Okay, I'm trying to share my slides. I'm having some difficulty with this. Okay, I'll try again. Can you see my slides now? Can you see my slides now?
No, Chris.
No, I can't, is it?
No.
They're still
Try
trying.
again. Oh, my apologies. Let me
Oh,
try again.
I hope you can sort this out, Akid.
I hope so too. Let me look at it one more time.
Oh, Chris, you have to do
No.
it. Okay.
Yeah, I know. I'm trying to do it now.
Yeah.
Can you see
Okay.
now? Okay.
Yes.
All right. My apologies. Right.
Excellent.
Okay. My apologies. I think these pictures, I'm sure all of us can identify with these pictures, and I think it's important to show this because it's not just the mortality and morbidity we're talking about, but all these things have really affected all of us. And I think even as Datuk Narimah mentioned about the domestic violence that have occurred, I think we also know that many social issues and family issues have come up. And I think we mustn't also forget the older people, the people who are living in aged care homes. I myself have had difficulty visiting my mom in an aged care facility. But this picture shows us how much it's affected our economy, and I'll leave it to Prof. Jomo to discuss in detail. These are satellite pictures of the nitrous oxide emissions or greenhouse emissions in 2019 before COVID over China. And as you can see, 2020 was a lot cleaner year, which is a good thing, I guess, if you look at collateral benefit. But let me take you back very quickly in the last 1 year, what has happened. On the 5th of January, this post came out from WHO. Before this, ProMed already identified in December, there were some cases of unusual pneumonias happening in Wuhan. And I'm sure all of us are familiar with the most famous seafood market in the world then, which is the Wuhan Seafood Market. I guess if you're going to Wuhan to visit Wuhan one day, I probably would want to visit this Wuhan Seafood Market. But at that time, people thought that there was very little human-to-human transmission, and most of it could be a zoonotic etiology. That was on the 5th of January. But soon after that, on the 9th, and there was some suspicions about it, whether some authorities were sitting on information. But nonetheless, on the 9th of January, they identified a new coronavirus. And that wasn't exactly surprising. The good thing about this, one, they could identify this new coronavirus. They could identify the gene sequencing of this virus. And that was a huge benefit for many of us, because with that, we led to this. WHO could release to the world that they have now identified the genetic sequences. And at that time, because we didn't have a good name, it was 2019 novel coronavirus then. But soon after that, obviously, if they could come up with a genetic sequence, they could come up with a diagnostic method using PCR, real-time PCR, to help us diagnose this infection. But these are critical moments. This short period of time allowed the world to get ready very quickly. And I think this is an important highlight. You can argue how fast China identified, or you can argue how slow China identified it. We don't really know, and then WHO is still looking into it. Nevertheless, a few days after the announcement to the world that this new virus was floating around the world, we could actually diagnose it in the laboratory. Clearly, our concern at the time was we saw the numbers spread in Wuhan, and more people got infected very quickly. But what worried us most was it went off of Wuhan very quickly, not just the surrounding cities in Hubei province, but also went to Thailand very quickly. And before the middle of January, Japan already picked it up. So clearly, as the numbers spread, it was clear that there was significant human-to-human transmission. And this was a wake-up call from WHO to all governments around the world that, look, this virus can spread from person to person. So in terms of control mechanisms, control measures, things have to change very, very quickly. I picked 23rd January because that's a special day. You know, it's basically 10 days from now. No, it's not because the United States had their first detected case on the West Coast. But indeed, when American got infected, I think the world media got a lot more attention. CNN talked about it repeatedly again and again. So it gave COVID-19 before and novel coronavirus 19 at the time a lot more airtime. But something else happened on the 23rd of January, which was really changed the world. And that was in the city of Wuhan. We know what happened. We know that on the 23rd Jan, the government of China imposed a lockdown on the complete city of Wuhan. And this, I think all of us, I think both including infectious disease physicians, public health specialists, we have read about it. We know this can be done, but we have never seen this on such a big scale in our lifetimes. And of course, at that time, it was the Wuhan lockdown. This is a city of 11 million. So locking down 11 million people at that time 1 year ago, I think was unimaginable. But that they did. And for those of us who had a chance to visit Wuhan before, these are very unusual scenes. Well, it's not unusual anymore. I guess we go to KL today, we might see something like this as well. So the world learned the word lockdown. Not the most common word known to mankind before 23rd of January, but after that, we did. And that was a highlight. This was one tool which we know in time immemorial among my public health specialists. This is a tool that they had in their box to control a contagious agent. But few times we had to impose, and never at such a huge scale the world has ever seen. But I think we know now after 1 year of lockdowns, not just in China, but in many parts of the world, including Malaysia, we know that it can also hurt. And I will leave that to my other colleagues who discuss a lot more details about how a lockdown can also negatively affect us. It will certainly bring the numbers down, there is no question, it's common sense, but there's a price for all this. Now, as time moved on, before the end of January, the numbers were growing up everywhere. Even in Europe, numbers were increasing. And there was a lot of pressure on WHO to say, hey, WHO is a pandemic. Well, they didn't move that far yet. They call it a public health emergency of international concern because certain criteria have not been met. Well, so certain countries, many countries move ahead, but certain countries still held their reins, thinking that it may not be as bad as they think it could be. The thing that has changed, obviously, is the naming. So before that, we always had the mouthful 2019 and COVID, but now we have, Dr. Tedros came up with coronavirus disease or COVID-19. And that was made sometime in February. Well, the world did move. I think despite many news agencies, I remember watching CNN, they were saying that there's enough evidence that it is a pandemic. It took WHO, I think, a month plus after the declaration of PHEIC before they said it was a pandemic. Now, obviously, we remember H1N1 in 2009, but this is on a much larger scale. Partially the mortality was significant, and as well as the way it spread around the world so very quickly. So pandemic, and I think if in all our lifetimes when we tell our stories to our grandchildren, I guess, yeah, we lived in the year of the Great Pandemic, and the Great Pandemic may not be 1918 in our minds, it will be 2020. Now, these are fairly recent numbers, and just to show how far, as Datuk Narimah has mentioned, now almost every country has had COVID-19 cases, and every continent has had COVID-19 cases around the world. And I will let Dr. Lokman discuss in more detail about the public health aspects of this pandemic now. Just a slide to show where we are in the country. I think this is looking at confirmed COVID-19 cases per million people. But whatever you put on the y-axis, you can see that rate shooting up. And I think all of us Malaysians and non-Malaysians alike living in this country watch this with trepidation. Something needed to be done. There must be a change in our course of control measures. As of yesterday, these are the last numbers, 141,000 people confirmed. 559 deaths, and certainly a large number, 30,000 over people still in active treatment. I'm going to move on a little bit to some of the key events that shape the way we look at how we control this virus. And I brought up this issue of asymptomatic versus pre-symptomatic versus symptomatic disease. And I'm sure many of us remember this a couple of months ago. We all know SARS, and SARS made it a little bit easier for us because during SARS, we know that transmission occurs after symptoms develop. And that framed our control measure in the earlier days of COVID-19 when we said, if you were not ill, you do not have to wear a mask. But this issue of true asymptomatic or pre-symptomatic has been well proven now. We know there's significant asymptomatic cases, and the estimation varies about around 50% in most parts of the world. It ranges from 18 to 80%. But if 50% people are asymptomatic and never have symptoms, unfortunately, they can also transmit. And there's plenty of documents now, plenty of journals, plenty of articles that proves that asymptomatic transmission does occur. And it can occur very quickly because so many people are asymptomatic. Nevertheless, I think it's still very clear, symptomatic patients transmit more effectively, and that is a fact. So based on this understanding of asymptomatic and pre-symptomatic, I think the way we use masks has changed. As I mentioned earlier before, we said use a mask if you are ill or not well. Don't use a mask if you are okay, because you want to preserve the mask for the healthcare workers or the frontline workers. But over time, with lots of information coming through, CDC moved faster than WHO, and so did the EU and the UK when they suggest that universal masking in public spaces was the right thing to do. And that's where we are now as of today. So that is an important highlight.
2 minutes more, Grace.
COVID. Thank you. Now, I won't talk about COVID in terms of symptoms. We all know these generally correct. These are the earliest symptoms, 80% mild symptoms, 15% requiring hospitalization, and those in ICU about 5%. But that was data really from China in the earlier days. As we test more and more asymptomatic people, the number of deaths, the mortality rate actually has reduced. And these are probably late figures from CDC from the US. As you can see, the estimated global infection in the world now is with 10% of the world is infected, then the infection mortality rate is about 0.2%. And of course, as you grow older, the risk of mortality is higher. Quickly on treatment, I will leave Suresh to discuss most of it, but I think there's certainly a vacuum, and I'm sure you're familiar with hydroxychloroquine. And of course, let's not go to bleach anymore. The way we did trials changed because the WHO came out with solidarity where 400 over hospitals in 30 countries came together to do this trial. But this trial was important. And for the first time, I think around the world, countries came together to find clinical information. And here, as you know, hydroxychloroquine, things like even remdesivir and lopinavir showed that they were not as good as we first thought they would be. We do have some bright parts. Dexamethasone is one, and we know that it does reduce mortality. And we also have now recently tocilizumab has also been proven to be very effective. Lastly, last couple of seconds, is vaccine. That's what we are looking forward to. And I'm sure Musa will discuss in a lot more detail. But I think one thing to survive, and whether you give credit to Donald Trump or to everybody else, I think it was high-speed vaccine. They got us there very, very quickly. And I think this is something that we can look forward to. Now our focus on control is a lot more towards vaccine. So with that, a quick summary of how we have got here in terms of an overview. And we are here today. We are now MCO 2.0. And I leave you to my colleagues to give more elaboration on the various areas. Thank you, Dato Narimah, for your opportunity. Thank you.
Thank you very much, Chris, for a very, very good presentation. You took 18 minutes. I give you the 3 minutes extra because we lost some time in getting your PowerPoint. May I now introduce...
I'm still short of breath. It's okay.
Dr. Lokman Hakim is our second speaker. He's going to talk about, like I said earlier on, the global response. He's a public health specialist, and he served the Ministry of Health for many, many years, more than 32 years. He was, of course, as far as I'm concerned, most visible when he was in the IMR, because he was one of the most active researchers in the IMR, mainly in the area of parasitology, including malaria. And in he retired, he went for early retirement in 2017 as Deputy DG of Public Health. He went for early retirement despite my pleading with him, do not retire early, but he did not listen to me. Currently, he is with the International Medical University and he holds 3 very prestigious positions there. First of all, of course, he's the Professor of Public Health in IMU. Secondly, he is the Director of the Research and Innovative branch of that university. It's called IRDI. It's too much for me to tell you about it right now. And thirdly, he's also a Pro-Chancellor of the university. Now, on the international scene, as I said earlier on, he still sits on the Technical Advisory Group for WHO on pandemic influenza preparedness. Therefore, he is the most apt person to talk to us about the global response to COVID, because he's got a lot of international experience and still sitting on the task force. So again, I would like to remind the participants, please put your questions on Slido. And Lokman, may I remind you, or you know how to get to your PowerPoint? Okay, that's done already.
Okay.
Thank you very much. Okay, Lokman, 15 minutes is all yours. Starts now.
Thank you very much, Datuk Narimah, for your kind words of introduction, and thank you also to the guys for inviting me to be in a panel of this forum. Well, we continue to be challenged by emerging and re-emerging infection as a public health problem. Over the last 3 decades or so, I think about more than 40 emerging and re-emerging infections have made their appearances globally. Although majority were self-limiting, but some were devastating, with high fatality and damaging socio-economic outcome. We have our own share of experience in newly emerging infection in the forms of Nipah virus, if I think many people still remember, in 1998 to 1999, with a case fatality of almost 40% and crippling the billion ringgit peak in farming industry. However, none of this infection escalated into a pandemic, although there were some scares with SARS, H5N1, and MERS-CoV. In some aspect, H1N1 can be, by definition, can be a pandemic, but fortunately enough, it's a very mild one. Now, 70% of these emerging and re-emerging was zoonotic in nature, i.e. it originated from the animal infection. The same is with the current SARS-CoV-2, which causes the pandemic 19 infection. No matter what the conspiracy theories tell you, but the genetic studies pointed to the sabicovirus of the horseshoe bat as its origins, and the pangolin, which has a high Chinese medicine value, as the probable intermediate host. And in Nipah, it was the flying foxes to the pig and to human transmission. So as of 31st December, this 2020, more than 83 million cases of COVID have been reported worldwide, with almost 2 million deaths occurring. Now, in fact, the world community through WHO has been preparing for a pandemic for a long time. Preparedness through national core capacity strengthening to detect, to prepare for and respond to health emergencies is the cornerstone of handling any public health emergencies. Now, that's basically what the international health regulation aim to achieve. This capacity may not prevent the global spread completely, but it helps to minimize the impact of the spread. Now, it is important to appreciate that when we are dealing with a pandemic, we are dealing with something novel, something new. Thus, initially, not much is known about this virus, how it spread, what its infectivity like, who are at risk, what is the nature and severity of the disease it causes, and how to prevent and treat the infection. So being new, everyone is susceptible, and therefore there's a potential for a sudden surge of the cases that may overwhelm the healthcare system and cause havoc to the socio-economic system. So effective and efficient surveillance system will keep us on alert, and our capacity to diagnose and to mount immediate containment response would allow us to buy the precious time to prepare the healthcare system, the socio-economic governance, as well as the rakyat to breeze through the pandemic in the long run, either towards ultimately ending the pandemic or to learn to live with this infection as an endemic state, under the endemic state. A more recent development specifically towards pandemic preparedness was the establishment of the Pandemic Influenza Preparedness Framework, or PIP framework. It was developed by member states and unanimously adopted at the 64th World Health Assembly and came into effect on 24th May 2011. Its key goal is to improve and strengthen sharing of influenza viruses with pandemic potential and to improve access of developing countries to vaccine and other related supplies. The Global Influenza Surveillance and Response System, the GISRIS, is a network of WHO national influenza and collaborating centers, play a key role in coordinating the influenza surveillance and sharing of biological materials. By assessing these biological materials, i.e. the virus, which is the key element in the development of vaccine and other related supplies, the industries contributed to PIP framework to a tune of about USD 28 million annually. And this fund contributed towards capacity building in member states, in disease burden studies, pandemic preparedness and development planning, risk communication and community engagement, regulatory and laboratory capacity, as well as surveillance capacity. Now, another global initiative which also contributed significantly to the early understanding of the SARS-CoV-2 virus and subsequently the developments of response tools from diagnostic treatment to vaccine development is the GIS-8. It is launched during the 61st World Health Assembly in 2008. GIS-8 is an open access system designed by the scientists for the scientists. The controversial issues raised during by a WHO member state in the early outbreak of the highly pathogenic H5N1 somewhat contributed to the establishment of this platform. It plays a vital role in the biannual influenza vaccine recommendation by the WHO GIS system and contributed significantly in the early sharing of the vital genomic information of SARS-CoV-2 virus when it first emerged. That was what Chris was mentioning just now. Today, more than 300,000 full genome of the virus have been shared from all over the world, providing important information on the evolution and geographical signature of this virus, as well as vital information on mutation, which may influence transmissibility, pathogenesis and disease, and the impact on the vaccine. So the number of genome being shared in this platform is also unprecedented in the history of any infectious disease outbreak. So if IHR, PIP framework, GIS-RIS, and GIS-8 are parts of the Global Preparedness Initiative, which contribute towards early response to the pandemic, and their role cannot be underestimated, and it underscores the importance of investment in preparedness. For example, rapid sharing of the genome sequence by China helped to speed up the development of the diagnostic protocol of COVID-19. The virus was first identified sometime around 3rd of January 2020, and the first protocol of RT-PCR available worldwide, it was established in 20 days later, just 20 days later on 23rd January 2020. Now, since the declaration of pandemic, the global community now continue to innovate in order to respond rapidly to the emergencies. And a groundbreaking global collaboration to accelerate development, production, and equitable access to COVID-19 tests, treatment, and vaccine, known as the Access to COVID-19 Tools Accelerators, or ACT-A, was established. bringing together various existing initiatives who has been working in silo before this, such as Gavi, FINES, CEPI, Global Fund, and World Bank, and WHO, in a concerted effort to produce tools for diagnosis, treatment, and vaccine for COVID. The goal is to support development and equitable distribution of this vaccine and other tools for us in the response to the pandemic. Now, the performance has been very impressive. In just 4 months, of the establishment of this platform, there are already 10 vaccines in the portfolio. Of course, 2 already are being registered in some countries. 200 more on follow-up. 1,700 clinical trials of treatment options, and 15 diagnostic have received emergency use license, and 50 more are under evaluation. Now, one key Act A portfolio is the vaccine development and equitable access to it. I think this is one that most people are talking about now. The global pandemic, of course, is already causing a lot of problems, millions of deaths, and disrupting the life of billions more. And the global economy is already losing on average of about 375 billion a month. So without effective treatment, unfortunately, until today, we do not have really good effective treatment, especially at the primary care level. The world is in dire need of something effective, such as vaccine. So, but equitable access to vaccines is the only way to mitigate the public health and economic impact of this particular pandemic. Now, COVID facility is a novel and innovative financing mechanism that will incentivize the industries to invest in vaccine development and production through a guaranteed procurement and provide the world community with a quality, equitable, and affordable access to the vaccine. So in terms of pricing, of course, I mean, the platform will leverage on the bulk purchasing power. Now, Malaysia pays all-inclusive price of USD $21.10 or about 83 ringgit per person for 2-dose regimen. I mean, it's relatively cheap compared to many of others commercial vaccine that's available. Considering that this is a new vaccine, right? However, because Malaysia opt for optional purchase arrangement, allowing it to choose what to buy. So in COVAX, there are a portfolio of vaccine. Members can just use the standard agreement, or you choose an optional purchase arrangement where you can select among the portfolio what vaccine to buy. So Malaysia chose to the optional one and decided to purchase the AstraZeneca for 6.4 million, which will cover 10% of the population. So under the standard procurement, it will cover 20%, but you don't have the right to choose any of the vaccine. But since we choose a particular vaccine, then we buy at 10%, and we bought a report saying that we have signed another purchase arrangement outside COVAX through direct nego for another 10%. Malaysia has also sealed an agreement with Pfizer, and I think everybody knows about this, about the 12.8 million doses of vaccine, which will cover another 20%. So there's already a coverage of almost 40% of the population. Now, the speed of development of vaccine is also unprecedented. Just within 1 year, we already have a candidate vaccine being registered. But to me, this is nothing unusual, considering that the urgency of the matter. I mean, we are facing a huge challenge, so we have to act very fast. And of course, there's also a huge financial commitment to support the development of the vaccine. But nevertheless, having said that, there's no compromise in terms of quality, safety, and efficacy assessment process, with the various gatekeeping processes, both by the medical ethics committee, because every trial you want to do, phase 1, phase 2, phase 3, you have to clear the ethics committee first. And this ethics committee will be looking at all the safety data before they allow those vaccines to be tested in human. And the regulatory requirement. So in summary, the world community...
Lokman, I'm so relieved you said in summary. You have 1.5 minutes.
world community has been spearheaded by and coordinated by WHO has been preparing for the pandemic for years. Indeed, Malaysia has benefited tremendously from the investment in preparedness. We have to accept the fact that we did well, we did an excellent job in the containing and flattening the curve during the first major outbreak in the country. The government received a thumb up from the rakyat for a job well done and received accolades of praises internationally, including WHO. But somehow, early success breeds some sense of overconfidence. And I heard bold exclamation to the public that we may not even need vaccine to tame COVID-19. I have voiced my concern that authorities doesn't seem to understand the key objective of flattening the epidemic curve. Why we locked down in the first place, in the first instance. I have advocated again and again to go back to the basic infectious disease prevention and control in managing COVID as a public health problem. I've warned lockdown cannot be the means of the end in infectious disease outbreak management because of the very high social, mental, and economic costs. Yes, we have no experience in managing pandemic before, but pandemic is caused by infectious diseases. Managing outbreak during pandemic or non-pandemic is the same. I mean, the principle of managing the outbreak, the principle. Only the intensity of measures that differs. In a small outbreak, the intensity of measures that you take in...
Are you winding up already, Lokman?
Yes.
Your time's
my
up?
last few sentences.
Okay.
Unfortunately, we are still struggling now. While our north neighbor and south neighbor are doing so well. So what goes wrong? Thank you very much. I end my presentation.
Thank you.
Very much.
Thank you, Dr. Lokman. We knew that we got the right speaker for this topic. Ladies and gentlemen, please submit your questions through Slido. We will address them towards the end of the session, after all the 5 speakers have made their presentation. I will now introduce our third speaker for today, Datuk Suresh Kumar. Suresh, may I take this opportunity to congratulate you on your Datukship. I believe you had it from Selangor rather recently. So congratulations for that. Datuk Suresh Kumar is currently the head of the Infectious Disease Department in Hospital Sungai Buloh. Earlier on, when I introduced Christopher Lee, I told you he was the head of infectious disease in Sungai Buloh. Now Suresh is the head of the infectious disease. And Suresh, may I also take this opportunity to congratulate you for the award that Sungai Buloh was given a few weeks or a few months ago for the wonderful management of COVID that you all guys have been doing in Sungai Buloh. In summary, I would only give a very, very summarized background of Dr. Suresh academic credentials. He obtained his MBBS from the from a medical college in Kerala, India. He did his MRCP in UK. And I was very impressed to know that he did epidemiology. He has undergone training in epidemiology from the London School of Tropical Medicine in England. It's such a wonderful thing to have a combination of clinical expertise as well as epidemiology. That's very, very useful and very, very important. And of course, he obtained specific infectious disease training, both in GHKL probably and the CRIS before, and in Melbourne. Well, there's a lot more in his CV that I don't have time to give to you, ladies and gentlemen. So Suresh, may I invite you now for the next 15 minutes to give us your presentation on the national response, and may I also comfort you by saying that we know that you are a clinician, you are not really in the Ministry of Health and Policy Making, but we'll see what you have to share with us.
Thanks, Dato. I think, as you mentioned, I've got the onerous responsibility of defending our response when the graphs are not going the right way. I will see what I can do for you. So this is the history of COVID-19 pandemic waves in Malaysia. I think as alluded by many of you as to what happened. Just to recap, to make the picture complete. We had the first wave in 25th Jan, mainly from tourists from China and their contacts with that. We had the first test for us with regards to managing COVID as a pandemic. In the second wave, when we had the Uda cluster, the Sri Petaling cluster, and clusters in immigration detention depots in Klang Valley, and we brought it down with a movement control order, and subsequently we had a relatively low infections, intermittent spikes that we were able to manage quite well. And the third wave that started in 20th September, clusters in Sabah, Kedah, Selangor, clusters in foreign workers accommodations, in clusters in detention centers have actually exploded. And all the things that we did earlier, don't seem to be enough now. And we'll have to ask ourselves what further fine tuning that we need to do. As you can see here, these green lines are Malaysians. Green and yellow lines are all local infections. We have very little imported infections, and the green lines are Malaysians, and the yellow lines are foreign workers working here, and so equally distributed with regards to the spread of the virus, right? And over the almost a year now, we have been doing a lot of things that some may not be aware of, and I'll just list it down so that everybody knows the stuff that has been done so far. So we obviously have a national CPRC that gives us the daily reports, and we have improved training on among the healthcare workers. We have strengthened point of entry screenings. The risk communication, we have now realized that we could do even better job, and I think there is going to be a whole government approach to risk communication, and some improvements happening there. We have expanded our laboratory capacities. We have expanded our hospital capacity and low risk centers. We have improved our rapid response teams. Infection control and PP, our personal protective equipment has been training, as well as procurement has improved. We have increased our influenza-like surveillance in clinic kesehatans, and also pneumonia surveillance in the hospitals. So any pneumonia patient coming into the hospital now gets a COVID test. So we know exactly how many community transmission is happening. And we have now, as you know, we have a central disaster management committee that has improved the interministerial collaboration. We've also had, at early stages, we had quite a bit of international collaboration. It's where we learned from China how to manage COVID correctly, and subsequently, of course, now collaborations for vaccinations. There has been increase in use of digital technology, and I think moving forward, this will get enhanced further. There'll be even more use of digital technology to monitor patients' health moving forward. We have learned to mobilize relief staffs from other states, and also from NGOs. We have done a lot of emergency procurement. We have come up with new laws and better enforcement with regards to accommodation in foreign workers, and we have enhanced capacity for vaccinations, vaccine development. As you know, we're going to produce vaccines. We're going to package vaccines, and also improving diagnosing therapeutic capacities. And of course, we're continuing to see what we can do better. With regards to the hospital capacity, there has been an increase in hospital capacity over the waves, and currently we do have almost 6,000 hospital beds, 466 ICU beds. We have 120 screening hospitals and 50 treating hospitals. We have a lot of ventilators available to spare. We have got about 30,000 beds in low-risk centers, and our number of laboratories that can do PCRs have increased to 66. So we have expanded a lot of capacity over the year. But let's look at a snapshot of where we are with regards to COVID just before the third wave started. So I'm pulling up dates in 11th September and this is 10th January to understand where we are in each of these areas, right? Let's go through one of these, right? So as you can, the positivity rate is 0.72% in 11th September. Now it's 3.75%. That means there is lot more. Every test picks up a lot more positive patients, which usually means that we are probably missing a few too. And so the positive rate has gone up. even though the mortality rate has come down, the number of cases of people dying has gone up. The biggest block will be, last time we had 500 active patients in hospitals. Now we have 27,000 active patients in hospitals. We had 9 patients in ICU. Then now we have 171 patients in ICU. And we had 5 patients intubated. We have 79 patients intubated. And that sort of tells you what has changed in the last 3 months or so. I talked about, I think there's mention about testing. Our positivity rate in the last 14 days moving average, 7 days moving average is about 8%, which is not good. I think it should be lower. And I think the push now is to use antigen tests, and extensively now we are starting to, now that we know how antigen test works, what are the weaknesses and strengths of antigen tests. I think there is a big push now to start using antigen tests to increase our testing capacity. So I believe in the weeks to come, our positivity rates should come down, right? And of course, looking at our projections that is done by the National Institute of Health, this looks at RT, the effective reproductive number is currently standing at 1.12. So when it's 1.12, what do we expect? So the expectation is, if it continues to rise like this, as of second week of Feb, we should have 3,000 daily cases, and the first week of April we should have 5,000 daily cases, and we have to ask ourselves, how will we cope with these kind of numbers? And that's a projection with this effective reproductive number. So I want to explain COVID as a whole as to what happens to every single patient that comes in, and so its impact on our healthcare system. This data is from our first 6,000 patients, 6,000 patients that we had in Malaysia. We could get detail with collaboration from NIH and also from ID physicians in all over the country, and the CRCs and all these hospitals. We're able to get detailed data of the first 6,000 patients that we have. And so, as you can see, first 6,000 patients, so we know half of them will have no symptoms. I think that Chris alluded to this before. Half of them have no symptoms, and half of them have symptoms. In this half of them that have symptoms, 88% of them have mild symptoms. You know, we monitor them, they have cough, fever, and after 4 or 5 days, they get better. About 12% of them go on to have severe disease. That means they require oxygen supplementation. Of the 12% who requires oxygen supplementation, 40% of them, we can manage them in medical wards, while 60% of them go to ICU. And if 60% of them that go to ICU, 1/3 of them will succumb to the disease. And so we start with a 50% asymptomatic infections, 50% symptomatic infections, and then we have an 80% mild, 88% mild, 12% severe, and then we have a 40% managed in the ward, 60% managed in ICU, and then we have a 1/3 of them pass away once in ICU. So if you put the whole group together, we now know that 6% of our total patients will develop severe disease. That means requiring supplemental oxygen. 3.7% of them will require ICU care, and at that particular juncture, 1.3% of them will pass on. That's the data that we use to decide on how we are going to cope with increasing numbers, right? So as you realize now, as our numbers increase, so now the health system has to adapt. And so what we did last time is not good enough now, and we need to adapt. And so the first adaptation, of course, moving forward, I think mentioned yesterday in a press release by our YB Menteri Kesihatan, that we are going to start home isolation for category 1 and 2 patients, provided they can isolate themselves at home. My Sejahtera will be extensively used to notify results and inquire regarding symptoms. We will also have COVID assessment centers set up for in-person evaluation of these patients. And for high-risk patients, after in-person evaluation, we will be monitor them through telephone or a web platform for these high-risk patients. And so we are going to remove many of these stable patients that are in our low-risk centers to stay at home, provided their home facilities are appropriate. If not, they will still continue to be isolated in low-risk centers. The second major things that we have made is because many of these low-risk patients are coming from foreign worker dormitories. The act has been amended so that we have increased involvement of employers. Will be involved in isolation and quarantine of foreign workers. So we're getting the employers involved in the care of these foreign workers, be it for isolation or be it for quarantine. Again, sharing the work that ministry has to do for caring for these patients. Okay. So, but still, having said that, but I still think these are not enough because it's still COVID-19 manages to overcome the health system. So I'll try to explain why COVID-19 overwhelms the healthcare system as we understand it, as we have realized it, managing these epidemics, right? So when the total number of cases is low, that's what happened just before 20th September. Cases were quite low. As you can see here, our patients, the majority of the asymptomatic, you've got a mild disease and you have a severe disease. And then when the public health system kicks in and you realize that they were able to diagnose most of these patients, this fraction is the diagnosed fraction. This fraction is the diagnosed fraction. They diagnose most of them and they get isolated or admitted to hospitals. There will still be a small fraction of undiagnosed infections, but they're majority asymptomatic and that is an undiagnosed fraction. There will still always be some of them, but this number is very small when total cases are low. But what happens when there's an increase in daily cases, more than what our public health system can handle? Every patient requires a detailed history taking to find out what were you doing the last 14 days, and each one of them have to be identified and then told that they are a close contact and offered COVID testing. So when that system gets overwhelmed, what happens? So this is what happens. So when the healthcare system, public health system gets overwhelmed, what we realize is that majority of the patients are being diagnosed because they're symptomatic. The asymptomatic group does not get diagnosed that well. And so when you look at the undiagnosed fraction and diagnosed fraction now, the difference is very, very different now. Suddenly now, a bigger proportion of patients are
okay, Suresh, 2 more minutes.
Yes. Okay, and milder patients are actually less represented. Asymptomatic is not so represented, and so that's what causes the burden in disease. As you can see here, this is seen in this particular graph where our ICU rates, amount of patients that require ICU beds are exponentially going up compared to what you see in normal times. And as the same thing, as you can see, these are what we have found in my own hospital. The proportion of patients who require category 4 and category 5 diseases requiring oxygen or ventilation has exponentially gone up. It's 15% required now. So what it means in real terms is every week now I have to open a new ward, a 28-bedded ward, to cater to these oxygenated patients. And so we started with 1 ward, now we have 8 wards, and we are now moving on to every week we'll have to open up 1 new ward can manage for category 4 and category 5 patients. And what has that resulted in? That has resulted in these are beds, these are not ICU patients, these are not ICU beds. And we have realized that in these states, the non-ICU beds, we have now more than 70% capacity. These are the hospitals. Again, 16 hospitals, again, there's more than 70% capacity. These are ICU beds for COVID-19. The 6 states have got more than 70% capacity already. And these 14 hospitals, ICU beds are more than 70% capacity. And some of these hospitals, as you can see, as Sarawak, for example, has not much COVID patients. So even before the start of the COVID, they're already more than 70% capacity. And so that is what is challenging, because even earlier, our capacity is not that high. Despite us increasing so much capacity in many places, there is a limit to how much we can expand so far. The other problem why this thing gets worse is we have realized now that COVID-19 we can't manage efficiently. I probably shouldn't write manpower shortage. I should probably write here woman power shortage, because
okay, Suresh,
majority of
your time is up. I'll give you 1 minute extra.
Okay, majority of them are actually women that manage it. Many of them require to be quarantined because of infections, and we realize that because of the PPEs, we need more staff per patient to manage them. And our death rates actually going up, And as you can see here, as of 10th of Jan, we already have 80 deaths due to COVID-19, and that's the reason why we think. And the last thing I just want to mention is who gets severe disease. As you can see here, this is based on our own data. As you can see here, if you're 71 to 80 years old, 22.58% of them will have severe disease, while 51 to 60, 8.2% of them will get severe disease. And so older you are, the more severe disease you get. The same thing is manifested in the mortality data. If you have 80 plus, 18% mortality, 60 to 69, it is 4% mortality. And so as the age goes up, the mortality rate goes up. And so how well we are going to prevent our elderlies from getting infected. And that is what is going to determine how well we are going to manage this COVID, how well we're going to manage COVID without overwhelming a healthcare system. It all depends on how well we are going to protect this age group. And I think that's what is going to determine our future, as a country, we are going to do COVID. And I think I reminded all of you, we need to flatten the curve and stay at home during this MCO period. Thank you.
Thank you. Thank you very much, Dato Suresh. I wish we can have more time for every speaker. Okay, we now come to Dr. Musa. And I've been going through the Slido questions. Musa, I'm warning you, most of the questions are on the vaccine. Anyway, I stake my reputation here today by stating that I cannot find anyone better than Datuk Musa to talk about the vaccine. That's why I insisted that we have it. And I must thank you, Musa, to make time for us today to be in this webinar. So indeed, Dr. Musa is not just on COVID-19 vaccine, he is the leader in Malaysia in terms of vaccinology, vaccinations, immunization. Trust me, I know, because when I was director in the Ministry of Health, I worked very closely with the MPA, especially with Dr. Musa, to look at child health, child immunization, and we made a lot of changes in the EPI of Malaysia between my program and people like Datuk Musa. So I know for sure how much commitment he has on vaccinations. Academically, Musa graduated from Cardiff University in 1982 as a doctor. He did his MRCP in UK in 1985, and he's a fellow of the Royal College of Pediatrics and Child Health of UK as well, and of course a fellow of the Academy of Medicine. Needless to say, Musa sits on a lot of international task force on alliances, on committees dealing with immunization. And by the way, he is also very, very active in NGOs, especially in giving solace and help to people in trouble in war-torn countries through his other alliances with NGOs. And we must, I really am overwhelmed at what Musa is doing. Currently, Datuk Musa is the pediatrician and neonatologist in the Damansara Specialist Hospital, the KBT Hospital in Damansara. Musa, you have got your PowerPoint. I'm glad you managed to do that. So the next 15 minutes is all yours, Musa.
Assalamualaikum and a very good morning. Dato' Narimah, thank you very much for the very generous introduction. Basically, my brief is tiga. To look at the efficacy of vaccines, secondly, to look at its safety, and thirdly, to look at the rollout of the vaccines in Malaysia. Now, this is a vaccine that has learned from our previous experiences with SARS-1 and MERS-CoV. The SARS-1, we actually have trials in phase 3 vaccines, by the Chinese. But you see, SARS is not very smart, you see. It killed 10% of its population, so there was no need for vaccine. Similarly, MERS-CoV, it killed 35% of its victims. So it's not a smart virus, unlike COVID-19. To survive, you don't kill your host, and that's why the new mutant strain B117 that's going berserk in the United Kingdom is very transmissible, more than 70%, but it is not as fatal. So scientists have learned from phase 3 trials with SARS-1 and MERS-CoV, and that is why we see this rapid development of the COVID-19 vaccine. Now, the major antigen is this spike protein here, right? So the antibody that is created by the vaccinees basically blocks the receptor binding domain. So it prevents the virus from sticking itself to the cell and prevents it from entering the cell and causing damage. So that is really a very smart technology. Yeah? Listen, with the mRNA vaccine, we've had at least 30 years of experience. You know, you may think it's 1 year, but scientists have been at it since 1990. So it's gone through preclinical phases in animals. And then phase 1, they tested on about 100. Phase 2, they've tested on about 1,000, right? And in phase 3, they've tested in at least 100,000. Then we know whether it's efficacious, and we have some idea of its safety. And now that it's rolled out in several countries in the world, we look at millions of cases and we'll see the rare adverse effects following immunization and its true effectiveness. Now, this is a snapshot of the vaccines that has been created for COVID-19. We've got about 63 now in clinical trials, 43 in phase 1, 20 in phase 3, and another 20 in phase 3 trials. Now, 7 vaccines have been allowed limited and early use. The Russian vaccines, the Chinese vaccines. Now, I'm not going to speak very much about the Chinese and Russian vaccine because it has been what I describe as peer review with press release. What we scientists are emphasizing on is evidence-based medicine, i.e. peer reviews with scientific publications. And for that reason, only I'm going to focus on 3 approved vaccines under authorization, i.e. the 2 mRNA vaccines and the vector vaccines of AstraZeneca. Now, one was abandoned. This was the joint venture between GSK and Sanofi. So there are basically 4 major platforms for the construction of the SARS-CoV-2 vaccine. One is the classical inactivated and weakened virus. The second one, this is where the Chinese vaccines, yeah, from Sinovac and Sinopharm, yeah. And then that's the second one is the viral vector vaccine. The one that has been approved for EUA, emergency use under authorization, is this AstraZeneca. And then the nucleic acid to approve the M messenger RNA and the protein-based vaccine. China has got one. I think it's CanSino Bio. Now, let's focus just on the RNA vaccine. Basically, the vaccine contains the mRNA. It is encapsulated with this nanoparticle. It is injected into the muscles, and in the cytoplasm, in the substance of the cell, it sits on the ribosome and makes the spike proteins, right? The spikes protein goes, and this is the one that creates the immune response. Basically, a specialized antigen-presenting cells engulfs the virus and does 3 things. One, it creates this beta cell that proliferates the antibody and blocks the spike protein from attaching to our human cells. And it also proliferates cytotoxic cells, which damages the infected cells. And thirdly is immune memory. Yeah, long-lived immune memory to recognize COVID in the future. This is something that's most worrying everybody in the world. Yeah, it's at the end of the day a balance between the benefits of the vaccine versus the risks, the adverse effects following immunization. And let me give you a perspective. Yeah, this is the odds an American will develop shingles. 1 in 3. The risk of you dying from COVID-19 in the United States of America is 1 in 300. In Malaysia, it's 1 in 250. The risk of you choking on your food is 1 in 2,700. The risk of you dying of influenza is 1 in 4,000. The risk of you dying from being struck by lightning is 1 in 160,000. Now look, the risk of you developing a severe reaction to the mRNA vaccine, i.e. death following anaphylaxis is 1 in 300,000. And another extreme and rare side effects of the influenza vaccine, i.e. developing GBS, Guillain-Barré syndrome, where you get paralysis of your limbs and your breathing muscles, is 1 in a million. So let's get our safety issues in perspective, right? You're more likely to die of COVID many times compared to you developing a rare side effects of the vaccine. Now, let me give you another perspective. On your right-hand side are the very severe side effects. This is anaphylaxis of all vaccines. It's 0.1 per 100,000. This is a side effect called interception with the rotavirus vaccine, 1 in 100,000. This is idiopathic thrombocytic purpura, where your platelets drop, yeah, and you can bleed from the measles, mumps, rubella vaccine. It's 2.5 per 100,000. Now, this is encephalitis following yellow fever vaccine. It's 0.4 per 100,000, right? Now, I am in this group, right? What is the risk of me being hospitalized for acquiring COVID? It's 12,000 per 100,000. What is that compared to anaphylaxis? And the risk of death per 100,000 is nearly 2,000. So let's again get a right perspective of safety issues. So the FDA and WHO has set a bar. The vaccine being made must be at least 50% efficacious. Now let's look at the Pfizer vaccine. They had about 43,000 participants. The efficacy is way beyond 50%. It is 95%, right? And when they look at adults beyond 65 years old with comorbidities, the efficacy, vaccine efficacy was 92%. And this is about 3 months of follow-up. They're going to follow up these patients for 30 months so that they can know the durability of protection and examine issues of asymptomatic transmission. The adverse effects, local and systemic, usually after the second dose, and more in those under 55 years old. Fever, 16%, fatigue, 38%, headache, 28%, chills, 18%. The older patients had slightly lower risk. Now, there were 2 cases of anaphylaxis in the United Kingdom. And in the United States of America, the FDA has calculated anaphylaxis as being 11 per million. Note, 11 cases per million. Again, I need to emphasize, this is data that is available on the public domain. There's some guy that was saying, no, where is the research? Where is the publication? He's either too lazy to read, or he's too lazy to read the 92-page dossier presented to the FDA, or he could have been online with the FDA to look at the process of EUA being deliberated. So this is the Pfizer vaccine. This is the Moderna vaccine. Now, Moderna, they, in my opinion, if I had a choice, I'll go for this vaccine. Why? They've got experience since 1990. And in fact, they've got mRNA vaccines in phase 2 trials for Zika, influenza, chikungunya, metapneumovirus, and cytomegalovirus. Yeah. But with the 1.7 billion USD from the United States, yeah, and from COVAX, they were the first to start the program within 2 months of receiving the genome from China. It's 2 doses, 28 days apart, and look at these phase 3 trials, 30,000 participants, and again, 94.1% efficacy. Yeah, look at the severe cases of COVID, all of them were in the placebo. This is amazing, meaning that there were no severe cases in the vaccinated arm, and there were no major safety concerns. What are the ingredients? Why I have to emphasize? 2 reasons. One, the anti-vaxxers, they tell the whole wide world that doctors like us put poisons in the vaccines. And the religious bigots, especially among the Muslims, says that it is haram. Now, look at this. Look at this data. This is Pfizer. mRNA is synthetic, right? There is no animal protein. There is no gelatin. There is no preservative, right? The lipids, these are chemicals, right? Polyethylene glycol, PEG, cholesterol, and salts, potassium chloride, sodium chloride, and sucrose to stabilize, buffer the solution. This is probably the most pure amongst all the vaccine. Yeah, so no issues of poisons, no issues of haram substances. This is the Oxford AstraZeneca vaccine. Now they are now in collaboration with Serum Institute of India. Why? Because SI is amazing. They can roll out 1 billion vaccines in 1 year. And they're also in collaboration with Gamaleya in Russia. Basically, this is the chimpanzee adenovirus, AD, and this is the gene that has been replaced. It goes into the DNA. It tells the DNA to transcribe the mRNA.
Okay, Datuk Musa.
Like
Datuk Musa, 2 more minutes.
Okay.
2 more minutes.
It proliferates the spike proteins and then creates an immune response. This is the paper. If you want to check whatever I'm telling you is fake news or fact, right? So the efficacy is 70%, right? There were no adverse effect, probably one case of transverse bilateral, which is still being investigated. So if you put the scoreboard, this is the AstraZeneca, Moderna, Pfizer, and you can see how effective they are. And the bonus of the AstraZeneca vaccine is that you can store between 2 and 8, unlike -20 and -70 for the Pfizer vaccine, right? In terms of numbers, you see that we've got something like 100,000 volunteers compared to previous trials. This is Prevnar, pneumococcal vaccine, 50,000. The human papillomavirus vaccine, 20,000, 22,000 in the trials. So huge numbers, yeah? And again, about safety, the FDA says that 90% of serious adverse effects can be detected within the first 2 months. So the CDC is monitoring this very, very carefully. The vaccine adverse effect reporting system is a passive reporting system. This is the active reporting system. They will send you a text message or email to make sure that you report any issues you have faced following immunization, right? This is the sample size you need to detect a very, very rare adverse effect. For an adverse effect for 1 in a million, you need 1.6 million. We've got that in the United States of America, and 21 cases of anaphylaxis was reported in just under 2 million Pfizer vaccines.
Okay, Musa, your time is up. I'm sorry.
Million. So finally, the cost, right? This is Moderna, 37 USD, Corona Sinovac, 30 USD, Pfizer, 20 USD. The cheapest is AstraZeneca, 4 USD. So in summary, I think we've got good vaccines on board. They are efficacious, they are safe, and I think we are ready to roll out in Malaysia. Thank you very much.
Thank you very much, Dr. Musa. So all of you ladies and gentlemen, among you who are the skeptics, the unsure, the uncertain, the suspicious, the confused on the vaccine issue, hopefully you have been enlightened by that presentation by Datuk Musa, because I did have some skepticism like 2 months ago, but my daily conversation with Musa has made me be very, very comfortable and confident of this vaccine. Now we come to the last speaker, but I would say this is one that will have a lot of, at least to me, the economic will have some political implications also, I'm sure. The economic implications, like I said earlier on, I sympathize with Professor Jomo because it's such a huge topic for you to cover in 15 minutes. But that as it may I just give you a very brief background of Professor Jomo. Of course, he is so well known. He appears on so many programs, and he writes so often and so well that all of us know who Prof. Jomo is, even if you have not met him. And I was impressed that he was really in academia for a number of years in his career. He taught in USM, in UKM, and even in UM. So he was in academia. But I first got to know more about Prof. Jomo from the international scene was when he was serving as the Assistant Secretary General for Economic Development in the United Nations for a good 10 years between 2005 to 2015. So that really brought up the name of Malaysia on the international scene. And he received some award, I can't even pronounce it, the Wassily Leontief Prize for advancing the frontier of economic thought. That's very important. The key word is thought. To advance thoughts on economy is something so major. And right now he is a senior advisor to the Khazanah Research Institution. So Prof. Jomo, the floor is all yours. I believe you don't have any PowerPoint slides. So can I invite you now, Prof?
Thank you, Dato Narimah. Thank you very much to G25 for kindly inviting me to be with you today. And I'm very humbled by the excellent presentations by our medical colleagues who have enlightened us on so many issues. I've learned a great deal in the last year, thanks to COVID-19. And it is largely due to colleagues like this who have taught me and enlightened me so much. Allow me to be to make some remarks rather hastily, and I've dispensed with a PowerPoint precisely because PowerPoint tends to enlighten, but it also tends to constrain one's presentation in important ways. I think it's important for us to first realize that the world economy has been in doldrums for some time. And in Malaysia in particular, it is important to realize that economic growth, industrialization or technological change has actually slowed down fairly significantly since the Asian financial crisis at the end of the 1990s. These are things against which we should understand the last year where we have experienced the impact of COVID-19. It is wrong, I think, to exaggerate the significance of COVID-19 in and of itself in terms of economic growth performance. But I think, as we will see, this has been quite important in some significant ways. I think it is important also to realize that the initial response to the pandemic has been actually very different in different parts of the world. And I think it is very unfortunate that we have not, in this country, paid enough attention to what was done in East Asia and the state of Kerala. Dr. Suresh studied in Kerala, and Dr. Narimah, you also studied India. I think you all know something about how exceptional Kerala has been. And the health minister of Kerala has actually the Malaysian government. I think Dato Lee would know about this for its help in providing aid in dealing with the Nipah epidemic, which they experienced as recently as 2018. So I think this all reminds us that Malaysia actually has had considerable experience in dealing with epidemics, as has been emphasized by others as well, and that we were actually reasonably well placed in that regard in dealing with an epidemic, having had experience not only with SARS, but also with MERS and with Nipah and with a number of other epidemics in the last 2 or 3 decades. Now, having said this, I think it is important to understand why, despite a statement as early as the 3rd of January, that that Malaysia was well placed to respond to the crisis, what happened and what failed. And I think it's very important for us to have an all-of-government approach in terms of looking at responsibility for this. Why did we not respond much more effectively? How is it that almost in all of East Asia, except in Wuhan city and the three surrounding provinces, there was no stay-in-shelter lockdown. There has not been a stay-in-shelter lockdown in the Republic of Korea, for example, or in any of the other countries. There have been stay-in-shelter lockdowns in very, very targeted areas. For example, in Hanoi, there has been a so-called commune, which is basically something like, a section in Petaling Jaya, where you've had a stay-in-shelter lockdown, but you've not had national stay-in-shelter lockdowns, but you have had a number of precautionary measures, public health measures, which have been very, very important in terms of containing the contagion and in terms of mitigating the pandemic. Now, I think it is also important for us to recognize that as early as the 10th of February, the Economic Action Council, I had the honor of being a member. I must confess that I had zero impact on economic policy during the 22 months of the Pakatan Harapan government. But finally, at the last meeting, I managed to get additional funding, and thankfully the Prime Minister at that time accepted the need, and the current Prime Minister was also at that meeting. So they all realized, I think, that there was an attempt at a response in terms of providing significant additional fund allocations to dealing with COVID-19 as early as the 10th of February. Now, of course, we also know that for want of a better term, the coup which took place in late February was quite disruptive in terms of organized governmental response. I don't think it is fair and correct to blame MOH officials, for example, for this, as some people want to do. Now, moving on very quickly, I think it is the initial government response in terms of Prihatin and later Penjana were actually reasonable. I think it was reasonable that there were such measures. I think they were unfortunately too imitative of what was going on in the West in terms of the nature of those packages. So as a consequence of this, three particular groups which are very important in Malaysia in terms of understanding the spread of the epidemic in Malaysia were largely unhelped. Not completely, but largely. The first, I think, to recognize is the role of what are called daily rated workers. People who basically, if you don't work, you don't get paid. And there are still millions of such people in Malaysia. It's very important to recognize that that is not a phenomenon of the past. We still live with that phenomenon. And for them, there was no real relief because of the nature of their contracts. Many of them have what are called contracts for labor rather than contracts of labor. And so the responsibility of the employer with regards to them is very, very low. And they do not appear anywhere in terms of the usual contract roles. You might see some of them occasionally when they are lining up to collect their bi-weekly salaries and so on and so forth, and often to pay off their alongs to whom they are indebted. These people were not particularly helped. Another very major group are the petty businesses. The petty businesses, which are very common in Malaysia, and many people who are essentially self-employed, running businesses at the family level. They are not in the category of so-called small and medium enterprises, which were also adversely affected, but we can come back to that later. The third group, and I think this has been very, very problematic in Malaysia, has been the treatment of foreign workers. Richard Ryat, who was Minister of Human Resources, estimated in the middle of the last decade that there were 6.7 million workers, foreign workers in this country, okay? Using information from telecommunications companies and so on and so forth. Of that 6.7 million, only 2.2 million were registered as foreign workers and recognized in the labor force. In other words, 4.5 million were undocumented workers who do not even appear who are not even recognized as such not only by employers, but more importantly, do not appear in most of our official figures. So often when we talk about numbers in Malaysia, our denominator is greatly underestimated because we do not count these 4.5 million people. But anyway, 6.7 million. And then we had a very unfortunate situation of, despite MOH initially saying that they continue their commitment to treating everybody and a universal coverage, etc., etc. We've had a situation where some politicians made remarks such as no foreign workers would not be tested, and so on and so forth. So the result of this, and one should date this and compare it with what was happening in Singapore, where the second wave in Singapore, as all of you will remember, was precisely at a time, was in the middle of the year, precisely due to the foreign worker clusters. And there was a great deal of attention to that. Some of us here in Malaysia were appealing to recognizing and testing the foreign workers, and there was more adamant responses. Again, I want to emphasize, not from the health ministry officials, but from the politicians, about how that these people should be ignored. So we had, in effect, what in football parlance would be called an own goal. By ignoring the plight of these foreign workers, we basically exposed the Malaysian population as well to transmission involving that particular vector. Now, if I may quickly move on, I think it is important to recognize also that, that there were a number of other measures, and the second set of measures is what is called Penjana. It basically, as the name implies, it is to generate businesses, or at least to keep businesses going. The efficacy of such measures is very much in doubt. In fact, some of the Penjana efforts were really relief measures particularly for smaller businesses. But we also know that most of the small and medium enterprises, who comprise 97% of enterprises in Malaysia, are actually largely ignored. In other words, 98% of SMEs, and I'm sure most of them were small rather than medium enterprises, were largely ignored by these relief measures. So we have a situation where it is, of course, very difficult because nobody can really talk about a new normal. Business as usual is almost impossible to return to, but what is a new normal? That is again unknowable, because there are known unknowns, but there are also unknown unknowns as we continue to ride out this pandemic. So what we have is a situation where the measures, particularly the Penjana measures, were basically inadequate, and the initial measures for Prihatin were basically extended to some extent. But some of them could not be extended because they were time-bound. And so we saw increasing unhappiness, and there was also the realization that many workers who continued to be on payrolls as long as their employers were subsidized will face the prospect of losing their jobs once this happened. Now, the official unemployment figures are not much help in this regard. And unfortunately, but I think it is fair to say that that a great number of people who have responded to this to the pandemic by self-employment in creative new ways, but there are very many other people who are not in a position to do so. But they are not conspicuous. And the tendency in Malaysian society is not to pay out of sight, out of mind, and hence we do not really know much about this. Now, the Department of Statistics did try to have some surveys very early on, but they were basically discouraged from continuing to, at least to publicize the results of those surveys. And so we have very, very little idea about what is actually happening on the ground in many parts of the country. Now, moving on very quickly, I think it is very important, as many of the speakers emphasized, we have an all-of-government approach. An all-of-government approach. And
2 more minutes, Prof.
Yes, you have a whole-of-society approach. Since I'm running out of time, let me emphasize that the G46, if I might dub it as that, letter last week, there was a promise from Minister Khairi that there would be it would get serious consideration. But I think it's important for us to emphasize particularly considering what Dr. Suresh noted, that you have already the adoption of antigen testing in Sabah, and this is probably going to be extended to the rest of the country, I hope. This is very important because it allows much less costly and very fast testing, and it allows us to because the high number of people who are pre-symptomatic and even more who are asymptomatic, we have to really do much more testing, as Dato Musa has emphasized for so many months. We have to do much more. We have to be much more targeted in our approach. The kind of approach we seem to have is kind of one size fits all and kind of blunt. And we really should be doing much more targeted approaches, as we find in many of the other countries in East Asia, and very successfully, I must say. And I think it's also very important for us to recognize that there have been innovations. There are innovations in so many areas, including, for example, there's a long list here, but since the moderator has reminded me I've run out of time, I won't go into them. But I think it is very important that in all the areas which we have discussed, and in other areas as well, there are many new innovations. We need to learn from best practices from all over the world, and this is
Prof. Jomo, your time is up. I'm so sorry I have to stop you. Half minute maybe?
Right. If I can just conclude with one last sentence.
Please.
I think the COVID, the budgetary response, unfortunately, in November was not bold enough. We need to have a much stronger measures, not with some voodoo economics, but with serious economics, much stronger and bolder effort to provide relief and as to keep the economy going, so that to avoid a temporary recession from becoming a full-blown depression. Thank you very much for your attention.
Okay. Thank you very much, Prof. Jomo. Your last sentence, I really like that last sentence. I think that really sums it up very well, but it's a huge challenge for the government. Ladies and gentlemen, I now come to the most challenging role of the moderator, because we have only until 12 noon and we have only now 21 minutes for Q&A. I have looked through the questions. There are many questions. Most of them are relevant and very good. I have selected about 15 or 16 questions. I've categorized them into 3 categories: vaccine, management, policy. Chris, do you have to leave early? Before Chris answers the question, can the panelists agree with me that we extend until beyond 12 noon? Can we go until 12:20? Are any of you in a hurry to go somewhere else? Chris, maybe.
I'm okay.
Yeah, don't worry, Dr. Narimah. I just switched to another Zoom meeting. Don't worry.
Okay.
I don't have to go anywhere.
So I think we will go to at least 12:15, if not 12:20, because there are so many good questions. Okay, I think I will not start with the vaccine category. I'll do that later. I'll go to the management category first. Maybe I'll put in more than one question at one time. Set number 2. Okay, because all this will be, except to Prof. Jomo, all this will be relevant to the 4 doctors, especially to Chris and Suresh. The first question is, why are private hospitals not managing or not allowed to manage cases? Please write it down, because I'm going to give you more than one question. That's from an anonymous person. There's one person called Dr. M. I hope it's not Ton M. There's one Dr. M who said, can we treat COVID-19 just like another influenza outbreak? If so, when can we do that? The second question. Question number 3, I think this is rather simple. Can a recovered patient be reinfected? I think the answer is already known. The fourth question is from Code Blue. This is directly to Suresh. Suresh, Code Blue asks, has there been incidents when Sungai Buloh Hospital had to turn away patients or to delay admission of a patient? That's 4 questions. Yeah, I'll add in the last one, 5th one. Please take this note from one person called ZMS. She wants to know to what extent are our current response, Suresh and Musa and Chris and Lokman as well, to what extent are we doing FFTIS? Are we adopting it full-fledgedly. Of course, you all know, for those of you who don't know, that is find, test, trace, isolate, and support. And I think 3 days ago, Musa wrote a fantastic article on FFTIS and how he's emphasized on the role of support, which is rather the weakest link at the moment. So those are the 5 questions. Private hospital, can we treat this like flu? Okay. The first question, please. Why are private hospitals not managing? Chris, would you be able to answer that?
I think let Suresh mention that one.
Okay, Suresh, can you answer that? Why are private hospitals?
I mean, I think private hospitals, it is changing. Initially, the plan was to centralize COVID care so that we can do it efficiently. But since the numbers are going up now, I think private hospitals are starting to prepare to start take care of COVID patients. It is happening as we speak. I think there is a meeting currently now going on at this juncture with our Deputy Health Minister and APHM and GPs, GP societies to increase the role of private practitioners in COVID care. So it is happening.
Okay.
As we
so it
Can
is.
I butt in? Since I'm from a private hospital.
Yes,
Thank you
Musa,
very much.
please.
Now, I personally disagree with this idea because COVID is a disease that must be managed in COVID hospital, dedicated COVID hospitals. Yeah, and I think you guys in the public hospitals can at least decongest 80% of your beds, which are stage 1 and stage 2 cases. Number 2, you can do decanting of all your non-COVID cases to a private hospital. We can look after them, right? And remember, many of the anesthesiologists, intensivists, respirologists in private hospitals are high risk doctors. They are well beyond 60 years old. This is unlike the specialists in the public hospitals who are Gen Y, 30, 40, 50, right? And we in the private hospital,
I never noticed that age differential.
So I think it's extremely important we do not expose our specialists who are high risk in private hospitals to COVID disease at this point in time. We can do better in other areas.
Okay, that's one view. I thought of that as well. You decongest with non-COVID cases. Okay, that is the first question. So can we treat COVID as just like any other flu? Can it be treated just like a normal flu?
Dr. Narimah, I mean, the large proportion of the COVID-19 cases will be asymptomatic. Many of them will have no complications. And I think clearly we have a profile, and we have a profile in Malaysia as well, who are the people who are likely to do well. So this group are the ones we can treat like flu, of course, minus giving the anti-influenza treatment, but the approach can be very similar. We just observe them, and the home quarantine will be something we can do. So in principle, yes, I think a large portion of COVID-19 cases, and we can profile them, can be treated like
especially
like
stage 1, stage 2.
Illness.
Okay, Suresh, have you, Lokman, you want to say something on that?
Yeah, just not on the influenza, but looking at the national resources in managing pandemic. I mean, we are dealing with a situation of pandemic.
Louder, please, Lokman. Louder, please.
Okay, in the principle, based on the principle of whole of government, whole of sectors approach, I think we have to look at the national resources in every sector, public, private, also and not only at the hospital level, but also even in primary care level. I mean, what's their roles in managing the pandemic? So maybe, I mean, I think the ministry in the initial phase do have that, I mean, the principles in full on. And I think there were some arrangement made with the private sector. I mean, some of the cases been shifted to, to the private sectors, non-COVID. I mean, because of the original idea of concentrating and maximizing the public resources for COVID. But as you move on, and we see that the situation is deteriorating, I think you cannot look only, I mean, as public and private kind of thing. You have to look as in total. I mean, even you look at the diagnostic capacities. I'm asking this question from the very beginning. We pride ourselves with 40,000 tests a day, but where are these tests? Are they spread out to the entire country? We faced problems when Sabah was hit by COVID because the delay in diagnosis. At that time, we already have 36,000 tests a day capacity.
Okay,
we know
okay,
that
Dr.
some-
Lokman, Dr. Lokman, point taken. I foresee we need another webinar just on this issue. Anyway, Suresh, I'll give you 1 minute to answer. Have you turned away patients from Sungai Buloh? Did you admit them late?
No, we don't turn away patients, but there has been delay in taking over patients. I think the issue here is not the category 1 and 2. Category 1 and 2 patients, we have no problem with beds. We have used ILKKMs and all this stuff. It is in the recent weeks, 1 to 2 weeks, when the category 4 patients increase, and that's the space in the main hospital where you need oxygenated beds, we struggle to move patients around. And so there has been a delay in taking them over, but no patient has been turned down because we know how fast they will deteriorate.
Okay. Okay, thank you very much. I'm so relieved. So, Code Blue, I hope you're happy with that answer. Finally, in this category, FFTIS, anybody wants to respond? To what extent are we doing FFTIS?
Before Musa talks, I think she will speak for 3 hours on that. But clearly, I think I can see the Ministry of Health trying to do exactly that. How effective we have been, how rapid and fast and thorough is the job, I think that can be questioned. Clearly, as Suresh showed in his slides, there has been an overwhelmed effect on the Ministry of Health, not just the clinical services, but also in the public health perspective. I think in Selangor, in Sabah, in Selangor, for example, we know from the ground that the contact tracing system has broken down. That's the fact, all right, because they just can't cope. So I think they are following their principle, but I think we have to make the system stronger. And I think during this current MCO, this is a time to make the public health response a lot better. And we have to bring new people from outside into the system because the current staff can't cope.
Can I
I'd like to hear from the clinician.
Okay.
But I will not give Musa 3 hours. I'll give him 3 minutes.
Impossible.
Thank you very much. Okay, I will call a spade a spade. Number one.
So long you don't call it a shovel.
The
So long you
Minister
call
of
it a spade,
Health
yeah.
has failed in this public health management of testing, right? I think since October, they've been told to switch to rapid testing. They refuse. They are so obsessed with PCR. This is what Prof. Jomo was saying, one fits all. Everything is PCR. You know, PCR, you only get your results after 3 days. On the 5th day, you tell the patient. On the 7th day, you isolate the patient. By that time, you have spread the virus. With rapid test antigen, we do it on the first day. Within 1 hour, we can get a result. Within 2 days, we can isolate the patient, right? And we can get contact tracing. So tracing, My Sejahtera is only using 4% of its digital app. With Sri Lanka, we are using it to trace patients, so we don't miss patients. We don't abuse our manpower. We can facilitate our manpower to other things. So it was a failure in tracing. We are doing very well with Sri Lanka, with due respect. So I think you need to upgrade your My Sejahtera and find, using Sri Lanka, we can find the areas, the hotspots, right? When you know the hotspots, you do what's called triage mass testing. This is what Prof. Jomo was saying. Then you can find the asymptomatic. You can find the pre-symptomatic, which was deliberated by Prof. Chris. And then you can isolate the asymptomatic and pre-symptomatic, which makes up 50%. Then you can bust clusters. Then you can stop the sporadic spread.
Okay. Okay, Musa, you made your very passionate and very convincing argument. Okay, now I'll go to the second set on vaccines. Indeed, you have answered the question to the first 2 questions that I have on my list. The first question was somebody anonymous. I think he asked, why isn't the RTK antigen test being done? So Musa has answered that question. The second question related to that from Dr. C.S. Liu is a little more indirect. Is there a reliable antibody test that can be used to monitor post-vaccination antibody level? In fact, Musa has answered not just for post-vaccination surveillance, it is also for screening and for diagnosis. So I think those 2 questions have been answered. There is a question, a very personal question. I'll ask it anyway, anonymous. I have allergy reaction. She or he did not say to what he is allergic to, and I'm an asthmatic. If I decline Pfizer vaccine, can I take Sinovac? It's a very personal question. Maybe 1 minute, Musa, for this question.
Right. Okay. The only absolute contraindication to the mRNA vaccine, i.e. Pfizer and Moderna, is anaphylaxis. Anaphylaxis means you fail to breathe, you got a blockage of your upper airway, you drop, your blood pressure drops, and you faint, right? Those is the only absolute contraindication. But if you're very hesitant because of your allergies, then switch to not the Sinovac, but switch to the AstraZeneca vaccine.
Okay.
Yep, because that is the one that's registered.
Okay.
The Sinovac is not registered yet. You know, neither is the Sinopharm's vaccine from China. The Chinese and the Russian vaccines are not registered.
Okay, thank you, Musa. That's a clear answer.
Published in scientific journals.
To Dr. C.S. Liu. Now, this question, two persons asked this question. One is from the Malaysian Pharmacy Society, and one is probably also from a pharmacist. Can community pharmacies be involved in mass vaccination? Because they are the most accessible to the community. They are there everywhere. And it is already being done in the United States, in UK, Australia. The second question, the second person, anonymous, asked the same question, and he quotes, it's been done in 36 other countries. Do we have any plan to do mass vaccination using community pharmacies?
Well,
it's a policy question, actually.
Yeah, I mean, this is based on my personal opinion about this. Okay, when we are dealing with a national strategy like this, when you want to mass immunize the population as quickly as possible, you have to use whatever resources that is available.
Okay. So your answer is yes. So your answer is yes. You are for pharmacies to be involved.
If the ministry say that they cannot, it's possible for them to immunize the whatever 40-60% in the period that they wanted to immunize, then what choice do they have? I mean, as long as within the medical system, this is possible to be implemented.
Okay.
Of course, there will be certain SOPs and guidelines.
Okay, so we need a policy on that. Once we have the policy, then the details will have to come out. You know, the logistics, you know, the quality control, the refrigeration, things like that. So anyway, we've got one view.
One caveat, Dr. Narimah, one caveat. Yes, I agree, but you must have facilities in case the 11 in 1 million anaphylactic reaction. Maknanya you must have IM adrenaline on standby. You must have your EpiPen. I have it in my clinic all the time.
Yeah, that's what I meant earlier on. Once you make the policy, the details are going to be, you know, the devil is in the details. Okay, so that is on vaccine. There's one more on vaccine, which, okay, I'll put that under policy. Maybe I'll ask that now. Because I've been talking about, but this is very long. Can private companies, can employers make vaccination mandatory from the employees? My answer is no, but it will take me 1 hour to answer that question. Because I was the desk officer who actually wrote the Prevention and Control of Infectious Disease Act in 1983. I worked on it. It was passed in Parliament in 1988. So I've really studied about mandating vaccination. So I think the answer is clearly no, but we don't have time to talk about that now. Yeah, but there is a question on employers. Now I go to the third category of policy. Prof. Jomo, somebody wants to know, what are the overall impact during MCO? Has that been quantified? I think it has. Many writers have come up and said we lost 3 billion in a day, 5 million in a day because of MCO. Somebody wants to know, what is that impact on the MCO, on the economy by the MCO alone?
Well, it's very difficult to assess this because we do not collect data which allows us to measure the impact of the MCO. So one needs to aggregate the different laws.
Okay.
But I think it's very difficult to measure things in terms of what is lost in terms of economic losses. You know, there's a tendency to do so at the world scale, as you know, Rima. And the result of it is that poor people's lives are valued less. Because they are considered to be less productive, less contributory, and so on. so forth. People in poorer countries, in developing countries, are considered to be less wealthy. So, for example, the economic losses due to non-communicable diseases, for example, you will find that most of the losses are happening in the developed countries, because that's where somebody who's, for example, obese is not able to go to work and perform and so on and so forth. There's a tendency, I think, that therefore I tend to take these metrics with a pinch of salt, It's very important also that we be careful about what is actually being measured. Many people, for example, think that the world economy is fine because the stock markets are fine. In fact, the stock markets are a perverse indication of what is happening in the world economy. Yeah.
Okay,
and then
thank you, Prof. I don't know whether you've heard about families on age. I'm now the consultant technical advisor to UNFPA. UNFPA Malaysia and UNICEF Malaysia, we have invested a lot of money to do a study on low-income families in Kuala Lumpur, how they suffer with COVID. And we have a sample of 500 families in PPR flats. And the results are, well, I think we expected that. The economic impact is actually major, especially on female-headed households, especially on women who are informal wage earners. We have a very rich set of findings on that. But the economy has really suffered, and very heartbreaking, there is no social protection. How many of the poor families, they don't have APF, they don't have SOCSO. So your last sentence earlier on, Prof. Jomo, was so true. The government just needs to do more. I mean, it is a difficult time. I have done 3 webinars on the social impact of COVID on poor families. And tomorrow I'm going to be interviewed by Esther Awani on the 3rd phase of the study. I'm doing the study with Dr. Muhammad Khalid, if you remembered him as the economic advisor to Tun Mahathir when he was Prime Minister. So that I've done 3 webinars, and there are many issues that really need to be sorted out. People are really suffering. And in 3 webinars, I mentioned 3 things. I mentioned the same thing 3 times, that one way is cabinet ministers to take a 10% cut in their salary. I even challenged them, if you guys take a 10% salary cut in your salary, I'll give up 10% of my pension. Nobody responded to me. Anyway.
I carry one figure in my head, you remember in the 2nd quarter of last year, our GDP plunged by 17%. Now, I calculated that, and that's about 250 billion ringgit.
Yeah.
That's a lot of money.
Yeah, you can see all these figures. Yeah, so this is something so serious.
Sorry, if I can come in on this.
Yes, Prof.
In the 2nd quarter, the US economy collapsed by 33%. In the 3rd quarter, it went up by 33%. But what does that mean? You're rising from a lower base, so you actually are still 11 or 12% short of the original. So a lot of people get confused by these numbers, and that's why I tend not to talk about them so much. But Dato' Narimah, your point, I think, is very important. I've listened actually to your webinars, and you've been very good on this. But I think it's very important to remember, for example, due to children not going to school, the supplementary feeding program in schools, for example, is discontinued. So what are children eating? If they get to eat meals, they get instant and things like that, which are very far from being nutritious. You know, so we have already so many diet-related non-communicable diseases in Malaysia, and being exacerbated, worsened very much by the kinds of things which
in fact, Prof, that was the first finding that brought tears to my eyes when these women said, we are buying less rice now because Maggi mee is cheaper. So my children are eating less rice. They're staying at home, they're not going to school. I have no money to feed them. It really brought tears to my eyes. So the only protein they can afford is eggs, and that's only perhaps 1 egg in a week. So people are really suffering. So that's very true. I said earlier on, gender-based violence has gone up by 200%. Depression, I think, Chris, you may have the figure. I think depression is going to double. So far, I can see very high rates of depression, especially among the women, female-headed households. Anyway, there's a long story by itself. That's why I said we need another webinar. Okay, now I go to the policy questions. The first question is from an anonymous, that she made an observation. There is a loss of leadership from the government for all of society approach in managing the pandemic, especially among migrant workers? What are your thoughts in that, on that? So that loss of leadership, not only among migrant workers, I think overall. Another question is quite alike to that. Oh no, this is quite different. What are the inter-silo institutions? What do you have in mind for inter-silo arrangements, intersectoral maybe? So this person is very skeptical of the single silo, the silo management by the Kementerian Kesihatan. You're not involving other people in this. The health system is overwhelmed. Musa wrote a very provocative article recently. Who exactly is overwhelmed? Is it the health system or is it somebody else? Who is overwhelmed? Okay, anyway, that's a big question. And this is something that the 46 people who signed those letters, the letter to the PM, has many reasons why they signed the letter. For me, one of the major reasons was because when I talked to DG, he didn't reply. I didn't expect him to reply anyway, about the National Task Force. Why is there no interagency national task force that involves not just the experts in the Ministry of Health? Because the Ministry of Health doesn't have enough experts, not just in Malaysia, in all countries. The Ministry of Health cannot handle this alone. I listened to the 4 Indian TV channels, and I'm so impressed with the National Task Force in India, and 2 of them are my friends when I was working in New Delhi. So this is one question. What are the arrangements for inter-silo? I don't know whether Suresh or Lokman or Chris or even Musa. So those are the 2 questions on loss of leadership, on lack of interagency, no national task force, and lack of transparent information and clear coordination. So these are very interrelated. Any one of you want to defend or to support this criticism on no intersectoral, no transparency, loss of leadership?
I will start, and obviously
yes,
others can chip in.
You are wearing the Minister of Health hat, yeah.
No, I think no is a very strong word. We can do more makes sense. No seems to be meaning that people don't understand the mechanics of what happens inside. So I think there is starting to have collaborations with private. We are starting to have collaboration with GPs to do more testing. And with regards to, there's a lot more NGO involvement in testing currently, especially after after what happened in Sabah. And number 4, the antigen testing has been rolled out in a bigger way after listening to what people say. But I think some of the thing that we are forgetting in this whole episode is how this virus infects people. The virus infects people 2 days before you know you are sick. And it finishes infecting people within 2 or 3 days of you getting symptoms. So there is so much prevention that we need to do, and prevention involves social distancing. And I really think we can up all the things that we are trying to say, but I still think as a society we don't come together and commit ourselves to prevention. I really think the amount of all the things that we are advising, use more antigen tests, bring in all more sectoral, are going to be a minimal increase in what we are doing currently. And I believe that all of us have to use our influence to convince the society to do more.
Yeah.
Well, I mean, on this point, I don't disagree with Suresh in terms of the society can do more. No question. I think that one we all basically agree. But a lot of the response from society is also driven by policy. So at the end, I think it is also up to the leaders of the day to plan policies that are pragmatic, that can be carried out on the ground. In my personal opinion, some of the policies and guidelines that we have come up, and we are very good at guidelines, sometimes we know there's the disconnect. It's not what's happening on the ground. And I think that's important. As someone who used to look after patients in one place, I think that's important. Our policies must translate on the ground. Otherwise, it doesn't work. And I think we need to learn from that lesson. But in terms of your intersectorial, I agree with Suresh. I think there can be more. I think there have been attempts, but I think it must be more. It must be meaningful engagement as well. I think we need to hear from a lot of other ministers, not just the few ministers that we're hearing from now. That's my 2 cents.
Yeah, correct.
Can I make 2 quick
so
points,
it is not
Dato'
zero,
Narimah?
but it's inadequate. Yes, Musa?
2 quick points. The first point is my appeal for transparency, especially with regards to data. It is really frustrating, you know, when you have to learn of Malaysian data from Johns Hopkins and Oxford. You mean we rakyat are not entitled to our data and must source from overseas? Number one. Number two, when the Prime Minister gave his announcement 1 or 2 days ago, we saw the most data ever, you know, in terms of the capacity of the hospital. Why was this not revealed much earlier?
Okay.
So number one, I hope there is more transparency.
Okay.
And number two, the point is, I think I am an observer, and I see in Chris, I see in Adiba, I see in the Selangor state government exemplary leadership. Why do I say so? I just give one instance. They are doing RTK testing. Amazing. They're looking at all the hotspots, yeah? And their positive rates range from 3% to 25%, and they're doing more. And number three, the government of state government of Selangor is actually putting aside X million so that they can vaccinate the migrant workers. They can vaccinate the 100,000 refugees and the 800,000, I think it's 800,000 migrant workers. It's important because Selangor is built on industry. So if the industry collapses, the state will collapse. So I think this is foresight.
Okay, Musa, point taken.
This is leadership.
We need more transparency. You know, like every day, everybody waits at 6 p.m. to see the Director General coming out, the number of new cases, the number of recoveries, and then we see the Deputy Minister showing off his designer shirts. You know, everybody waits. Oh, I wonder what shirt will I see today? I wonder how many new cases will we see today? I mean, come on. We deserve, I think the rakyat deserve more information on some basis. So this reminds me of what I used to tell my staff when I was in the Ministry of Health as director. I said, okay, you get data. Data is useless until it becomes information. You transform that data into information, and that information is not useful until you transform that into knowledge. And if you're good enough, you can go to the 4th level, transform that knowledge into wisdom. Not all of us are wise. Sometimes I make the most unwise decisions. And with that wisdom and that knowledge, you can have opinions, like what the 46 people said to the Prime Minister. So this is so important that the rakyat, I mean, you have to really respect the intelligence of the rakyat. So time is running short because I'll give you the last question now before we wrap up. The last question is something that G25 has been mulling over and discussing. One of the reasons is because Professor Adiba is in G25 and we really support her on this big issue. Chris knows about this, Suresh knows, even Lokman knows, about prisons and accommodation of foreign workers being so dismal. I think of the 39 prisons in the country, I was told half of them are already paralyzed. So these are where the most vulnerable are there, and the infection with no social distancing infection, and now we already have one variant here, the UK variant, so that the future is really very dismal. And this person, an anonymous, observed that we have only been reactive, we are not proactive. What are we doing to remedy this situation? What are we doing to improve prisons, to improve accommodation of foreign workers? I don't know who has the answer. I don't.
I think MP Liu Chin Tong has addressed the situation, and he's got on board the Deputy Speaker, Azalina, I think, and they have a parliamentary committee to address this issue. This is long overdue because one of the major clusters of outbreaks were the prisons and the detention centers. So we fail our rakyat in this sense.
Yeah, I'll take this opportunity to say kudos to Azlina Osman, Deputy Speaker. She responded immediately. She gave an appointment to Adibah immediately, and she said she's going to push this forward. Well, it takes a woman, I guess, to be that proactive. Sorry for being sexist. Anyway, before we wrap up, I'm the only woman here. We don't have a woman expert among the 5 of you. How sad. 2 things that I like to announce here. Number 1, like I said earlier on, I foresee another webinar by G25 addressing some or one of the issues that you have raised. I will talk to Tan Sri Sharif in the next 1 or 2 days, because we have one webinar slotted for April. We are bringing in a very, very famous Islamic scholar. Probably, I think we want to address the issue of unity among the Ummah. So Mustafa Akyol, the Turkish man who lives in America, he's agreed to come in April. But April is a long way off. I may want to request Tan Sri, if we have money, to have another webinar on one subtopic of COVID-19, maybe in late February or early March. I'll get back to you guys if we need one. Maybe, you know, private sector or whatever. Let's identify the topic. The second announcement I'd like to make is, for all the participants, I really appreciate the questions you have put up on Slido. I tell you, they are all very good questions. Almost all are relevant. Almost, well, I would say 99%. I'm so sorry I cannot answer, cannot give to the panelists all these questions. But please be comforted by the fact that we, the organizers, will answer all these questions, and we'll be posting them on our webpage, on this webinar webpage. Within a week or maybe 2 weeks, we'll be ready with the answers. We'll get back to the panelists to give us the answers to these questions, because these questions really deserve to be answered, but unfortunately, we do not have time to do it today. And before I thank the 5 very awesome, I would say, awesome panelists, I really enjoyed the session today, and I learned so much. I really did learn so much. One more announcement is, like I said, we plan, G25 plans to do this webinar of public interest perhaps once a month, but as you know, it does cost money. I'm staying in a studio here. It doesn't come free, by the way. So we do need some funding. We are rather poor, and we do have an avenue for people who wants to donate to Edunity Foundation. Maybe Akid or Jasmine can just show on the screen right now where to give if you want to donate to this foundation. The more you donate, the more we can do webinars, however small. Some people just say, I'll give you 10 ringgit, 20 ringgit. We are so thankful. Of course, there are people who give us 10,000 as well, but only 1% so far. So people give 200-300. So we are really, really bersyukur, alhamdulillah, and really very thankful, because I think the public really needs to be educated. And Edunity, the word is Edunity. That is the aim of G25. We want to be the impetus and the force behind educating the general public over issues that affect them, that have impact on their lives. So inshallah, we will do this if we have the money. So you can donate that. You can donate any small amount of money. And therefore now my final duty is, of course, to thank Datuk Dr. Musa, Datuk Suresh, Datuk Christopher, Lokman and Prof. Jomo. I must really thank you for agreeing to be a panelist today, and not just agreeing, and to be here and giving us your wisdom, your knowledge, and for Musa, your passion as well. So this is something that is something we value very much in this. I don't know whether anybody from G25 want to give a vote of thanks. Tan Sri Sharif, are you online? So I have done my duty. Thank you very much. We need to give you the where to give the donation. So on behalf of G25 and Edunity Foundation, thank you very much to all the participants. I believe there were more than 400 on Facebook and on YouTube. Thank you very much. I really, really am grateful. So, Assalamualaikum warahmatullahi wabarakatuh dan salam sejahtera.
Waalaikumsalam.